So now let me move to our first panel. And we are going to ask this very important question. Dr. Basu has showed us how critically important screening is. It's a simple intervention and it makes a long-term impact on death rates and the numbers of people who then go on to get cancer. So why aren't we doing this? The first person who's going to speak to us is Irisa Syriza from the Dutch colorectal cancer screening. She's going to give us an introduction to what they've done in the Netherlands to significantly increase their participation rates. And then we'll have a series of people on a panel who'll just give a short message about the specific challenges that they've come across in their country. And we'll hear from Professor Sylvain Manfredi, the Deputy Secretary of the Francophone Federation of Digestive Cancer in France, Dr. Morten Rasmussen, the Head of Intestinal Cancer Screening for the Capital Region of Denmark, and Professor Jaroslav Regula, who's the coordinator of the National Colorectal Cancer Screening Program in Poland. So across the continent, we'll hear different experiences. But let me start with you, Iris. How did you manage to get your rates up? Because the Netherlands has obviously made impressive progress. Share with us, what was your magic sauce that you used to get people involved? Iris.
Thank you, Tamsin. And thanks for having me speaking on this interesting summit. The question is how to increase participation rates in colorectal cancer screening. I'm not 100% sure if I can answer this correctly, but what I can do and what I'm going to do today is tell you how we organized our program in the Netherlands. And we have a good participation rate. So we have some insights on how and why we think this participation rate is so high. So next slide, please. Let me shortly tell you something about the Netherlands. We started today with asking about if the sun is shining. Well, here definitely not. It's cold. We're on the west side of Europe, next to Belgium and Germany, across the sea from the UK. We're a really quite small country and really dense country. We have around 17.3 million people living in the Netherlands. Next slide, please. Our colorectal cancer numbers are shown on this slide. We have around 12,000, almost 13,000 new cases every year. And in total, 82,000 or 83,000 cases. More male than female, which would not be a surprise to you, and more older people than younger people. Around 80% is older than 60 years. The 5-year survival rate in Holland is for stadium 4 people, it's less than 5%, and stadium 1 around 90%. So that's a huge difference. And then mortality is still around 5,000 deaths per year. Next slide, please. We took our time with starting this program. I think even in 2002, we started to do some research, and in 2006, that developed into a pilot. As you can see, there were a lot of steps taken in between. We have a very, how do you say it, a complex a way of being organized in the government, and there are a lot of policy decision making before we started to do this program. Finally, in 2014, we started, so that's 12 years after the first study was started. And even in 2019, which was last year only, we got our rollout totally complete. So that meant that we invite every person in between 55 and 75 years in the Netherlands. Next slide, please. This is an oversight of how we are organized at the government. I work for the at IVM, the blue square. It's the National Institute for Health and the Environment, Public Health and the Environment. We're part of the Ministry of Health, which is next to us. We have the inspection who has to control everything. And we have a private party which executes the screening for us. These are the screening organizations here set as SO. We set the framework, and they execute the framework. And in the preparation and also in other big decisions we make, we have a health council that advises, and also the Finance Institute. Next slide, please. So where I work, as I said, we make the outline, the framework. We do the national coordination, and we have direct contact with our stakeholders. We're responsible for financing the program. We set the quality standards. We do the monitoring and evaluation of the program. We organize the uniform information to the public and the involved professionals. And also we make sure that the programs improve, and we advise and inform the Ministry of Health. So we're one big center with a lot of population-based screenings, and the colorectal cancer screening program is just one of them. Next slide, please. Our program, this is the outline. We have a fit-based program with a cutoff level of 47 micrograms. And we invite everyone between 55 and 75 years, men and women. Every 2 years, they get a personal invitation at home. And if the test is positive, so above 47 microgram HB level in the feces, we have a follow-up with colonoscopy. Next slide, please. This is the results of last year. So we invited 2.2 million people, and we have a participation rate of 72%. As you can see, women are more likely to participate than men, 74 over 68%. And we had 67,000 referrals after a positive fit. More men than women. And 85% of them went for a colonoscopy. We found last year 3,000, a little bit over 3,000 colorectal cancer cases and 80,000 advanced adenomas. And on the picture, you see that when the cancers are screen detected versus clinically diagnosed, we have a lot of more stage 1 cancers detected during in our screening program. And the survival rate, as I told you in the beginning, is much more positive for those people with stage 1 instead of stage 3 or 4. So next slide, please. So this is the big question of today. How do we get the 72% response rate? Next slide. We think that multiple factors contribute. In the beginning, we create a lot of consensus making this program. We did some careful piloting and some careful planning about our program, and we think, a very good invitation structure. On the page or the picture, you see our program. So we sent the selection of the population this purple envelope. They can do the test at home and send it to the laboratory, and they either get a positive response or a negative one, which means you need to go for further diagnosis to the hospitals. And after that, you either are under surveillance or you can get treatment. So next slide, please. I already see a question, but I'll come to that later, I think. So what about this creating consensus? As I told you in the beginning, we already started in early 2000s with different studies and also different institutes who involved in these studies. In 2005, there was a consensus meeting with all stakeholders evaluating this research and decided to implement the FOBT screening. And in 2006, the pilot studies comparing participation and the yield of the FIT, the GFOPT, and the sigmoidoscopy were held. So I'll tell you something later about this. Next slide, please. this is the results of the pilot screening determining which was the optimal colorectal cancer screening method for the Dutch population. I can, if somebody's speaking, I cannot see my own slide. I think on the left side there's a participation rate. Oh yeah, we can see that the greenish blue one is the FIT, and we have over a 60% participation rate. And on the right side you can see the yield of the different methods we piloted. So next slide, please. It turns out that it was really clear that the highest uptake was with FIT. Already after 2 rounds of FIT, it outperformed all tests and detection of advanced neoplasia. So it was also the most cost effective. So I think in the consensus meeting, it was really clear that FIT was the best way to go. So next slide. Then one of the other successes of the Netherlands is, I think, the careful planning we do. We have an ICT IT system. It's called Screen IT, and it's actually the center of the whole program. Here in the picture, you can see all the different steps, and it all goes back and forth from this IT program. We get from the municipal records from the government, so we have all the database records. Be careful, select the target group. We invite them, and when they send their test back, it all comes back in this system. And I have some good news to tell you. We try to make our Screen IT codes, so the source codes, we make them open source, so they are now available maybe for other countries also to use and to see, maybe have the same IT program as we developed for the Netherlands. And on my latest slide, there's the website, but you can also always send me an email, and I can tell you where the codes are. Also, what we made last year were different fact sheets. So obviously our information is mostly available in Dutch, but we made sure that we made some fact sheets in English to tell you about the program. We have one about our program infrastructure, and also about the quality assurance and our lessons learned so far. So next slide, please. So then our invitation procedure, we actively invite the target population, as I told you, every 2 years. We sent them a pre-invitation letter, so tell you that after a week or 3 after that they received the FIT in the mail. Then we sent the sample kits and then a reminder also, and that really helps because I think after the reminder, people around 15 or 20% of the people respond after that. So it's good to send a reminder, I think. And this is all automatically generated by our Screen IT system, as I told you. All right, next slide. Then we have the follow-up. Yeah, you got a letter in the mail telling you if the result was positive or negative. If you had a positive test, you are automatically sent for a colonoscopy to a hospital near your home. So you already have an invitation for the intake interview within 2 weeks or 2 or 3 weeks. If the participant doesn't want to go to that appointment, they have all the room to either by email or online or by phone to reschedule to either another hospital or another time. Yeah, next slide, please. So the question is, are the participation rates just because we are Dutch? I don't think so, but let me see, next slide. You can maybe think like the lower the southern you go, the participation rate goes down. You see here the Netherlands, quite high, Flanders a little bit lower, France even lower. But then next slide. we see the Basque country in Spain, which also has a really good participation rate. So we think it doesn't have to do has to do anything with the fact that we are Dutch. And next slide. Because also the France department of the Basque has a lower participation rate. So we do think that it has to do with the way you set up the program. Next slide. To summarize, we think to achieve high participation, it is important to create consensus within different stakeholders, carefully pilot and plan the program, and have a well-organized invitation structure. Next slide. But remember, I wanted to tell you that quantity isn't everything, it's also about quality. Next slide. I think we have still also in the Netherlands have remaining challenges. For instance, how can we receive more low socioeconomic status target group? The people also mainly in the city are less likely to participate than in rural areas. We obviously saw that women are also more likely to participate. And we also we are still can improve on excluding participants who are not eligible for screening, because now we invite everything, even people who already have colorectal cancer or have a history in bowel disease. We think that the sample taking can also be better. Some people just send their whole full test and envelope back to the laboratory. So we cannot really always maintain the same quality, or they have to resend the test back. And I also want to tell you that we are really focusing on sustainability and having less plastic send out in our country. For instance, by people who don't respond 2 times in a row, we now from next year only send a paper invitation instead of the whole plastic set. There are obviously, we think also maybe some chances in risk stratification, but there's more research to be done, and maybe also lowering our age group. And so I said, et cetera, because I think there's still a lot to learn and to improve. Next slide. Oh, this was the last slide already. As I told you, here are some links. We made some fact sheets. Also, our Screen IT is open source. And this is also my email address for any further questions or further contact. You can always reach out to us. So special thanks to all the people who helped with this incredible program. And a special thanks to Iris Lansdorp, who is also presenting today with collecting together all this information. So
great. Thank you very much, Iris. What an interesting presentation you've given us. It's very useful to understand how you broke it down in the different steps. And, you know, it's taken time to build the consensus, the relationships, the infrastructure between the different elements in the healthcare system, so they're all working together. And I love the fact that you're also building in the issue of sustainability and plastics into it. So these are some very useful points. I'm now going to invite some input from our 3 members of the panel. And Iris, I know you were keeping an eye on the chat. We've had several questions for you. And after our panel members have made a short intervention, I'll bring you back in to respond to some of those questions.
Yes.
So let me start with France and Sylvain Manfredi. Tell us a little bit, just 2 minutes, what's going on in your country? What do you see the key challenges, and how are you increasing your participation rates?
Good morning, everybody, and thank you for the invitation. In France, we have a low rate of participation, about 30%, and we fail to increase it. And I think it is an organization problem. In France, the screening is based on a GP who deliver the test to the population, and we don't reach the 45% or 70% we want to reach. The solution is probably the same used in Netherlands. I think we would move to the invitation with FIT to increase the participation rate. We are going to do that in France in the next year. Several solutions are in course. We are going to permit the order of the test by mail for all the population, the target population, and we are going to experiment the send of the test directly with the first invitation. So I hope we are going to increase the participation rate in France, who is a real problem to reach the population who is historically reticent to screening and vaccination and prevention. I think it is important to do a program for the prevention in school, in medical community, everywhere.
Great, thank you, Sylvain. So clearly France has looked at its low rates and decided to move from a GP-based system to the more proactive invitation, where you would send out the invitations, the FIT, and even the tests themselves. And hopefully you'll move up the participation rates. Okay, let's hear from, we're now going to go to the north. Perhaps it's even colder up there. Morten, what's the view from Denmark? How have you been trying to increase your participation rates?
Okay, good morning, Europe. The weather is a little bit gray outside, but we don't have snow yet. But in Denmark, we are very alike the Dutch screening system. We use a FIT screening system, and we were starting the first screening route in 2014. And to avoid capacity problems, it was performed in 4 years. And after that, we have invited people with the FIT screening every second year. So now we are actually starting on the third round. But our participation rate is lower than in the Dutch study. It's 64 in the first screening round, and it's about 62 now. And we have the same group with a lower participation rate demonstrated for other studies, for instance, in the Netherlands, that men living alone with a low education, are unemployed, and people with non-Western immigrants, they have very low participation rate. So what we're looking into now is, should we do some extra work for increasing the participation group in these subgroups? And they are very difficult to get in communication with those groups, because I mean, we cannot send our employees out in the bars in the night talking about a screening program. The interesting thing is, when we actually try to invite people non-participation, it seems that they are not aware of the consequences or of the benefits of participation in the program. So about, I would say, a quarter or 35% actually saying, okay, we didn't know, and then they participate. So it's obviously that we need to get these subgroups to talk to the subgroups in another way, just sending out by mail the invitation. We also send some information from the government and for our health institutions to provide a higher participation. However, they don't seem to read it. I mean, they are used to a lot of information, but we have to in a way get a better communication to these subgroups. And in Denmark, the general practitioners haven't any thing to do with the screening program. And as Iris said, one very important issue is actually to have a communication ET background system who is well organized and well fit into all our pathologies registers and all the patient registers we have in Denmark. But we still even after 6 years we still have the problem with the subgroups.
Okay, thank you. So you've got sort of quite high levels. You know, you're already above 60%, and that's when we saw the charts that were shown by Dr. Basu. That's already higher than some parts of Europe. But you've found the same pockets of population that are just not engaging and not being drawn into the system. So this is clearly an area when we come to the discussion that we need to pick up on. Let's now hear from our third panelist, who's going to give us the insight from Poland. And let's hear from Professor Regula. How are we doing in Poland?
Good morning. We yesterday had a trace of snow, so it's something new for Europe. We started colorectal cancer screening in the year 2000, so it's 20 years already. And from the beginning, it was the primary colonoscopy method chosen for this task. And we have two organizational systems. One is opportunistic and one is with invitations. Invitations started in the year 2012. And we observe dropping down of the participation rate in the invitational program. In the beginning, it was 35%, but now we have below 20% of participation rate to invitations to colonoscopy. So the reasons are probably very multiple, and it's no time for discussion for that. But we wanted to check whether introducing fit testing would improve participation rate for the invitation to colonoscopy. And we started and already have results of randomized controlled trial on 12,000 participants divided randomly into three groups. One was the current standard invitation to colonoscopy. The second was the sequential method, where we invited for colonoscopy, and those who refused, we proposed fit testing. And the third group was the choice group, where the people from the start were asked to choose between colonoscopy and fit. And the results are that the colonoscopy group had about 70.5% participation rate, and introducing fit into both groups, sequential and choice group, increased the participation to about 25-26%, so about 9% increase in participation rate. However, if we looked at the intention to treat analysis of the advanced neoplasia detection, there was no differences between the three groups. So this was roughly the same on the intention to treat analysis. So if we think that the choice group is in fact some sort of fit only, so in Poland we have not reached the levels of 60% or above. It's still about 25% at the best if we introduce or we add the option of fit to colonoscopy invitation. So there are other problems, and Okay, I think there are, of course, many reasons for the low participation rate, but one of those is just the characteristics of the society, the trust to the healthcare system, the education, the many other reasons that are probably not known also. So this is the situation in Poland. Thank you.
Thank you. So now we've had some insight from different countries in Europe. Let's explore some of the questions that have come forward. And if you take a look in the chat, we've got a couple for you, Iris, about the Netherlands. You're being asked, do you work with patient advocacy groups to raise the awareness? Are you planning to lower the 50, threshold for starting them? We've asked, if patients choose not to go for colonoscopy, do you offer them CT colonography? And do you know how much the pre-invitation letter added to the uptake? And is there opportunistic colonoscopy screening? So Iris, you've got lots of questions. Let me leave them for you to answer first before we go into some of the other questions. Iris.
Thank you. Thank you for all the questions. Yeah, we do cooperate a lot with patient advocacy groups. But not really yet too much on advertisements in that or more because we already have a pretty good response rates, and we're also very maybe Dutch and rigid about informed decision making. So we try to give a lot of information, but we also think that it's everyone's choice, and we don't want to push it too much, but it's always a bit of a discussion on how far you go. But the patient advocacy groups really work along with us in a lot of working groups in making the information. They obviously are a big influence on which studies they finance. So yeah, we have a good collaboration. Yeah, there are not really plans to lower the age, but there are to 50. We start at 55, but there's a lot of attention from the public and from different how do you call them? Also patient groups actually they go to the government and say you have to lower the age. But next year we're going to evaluate the whole program and also look into the age group and the target group. And there's a chance that we lower, or even maybe higher, but I think more likely to lower the age. So it is a chance, but not really concrete plans yet. What was the other question?
Opportunistic, and also what if people refuse a colonoscopy if you offer them an image colonography?
Yeah, I don't think we really offer them like, oh, you can do this now. But there is a group, I think only 1% of the whole referred target group who uses CT colonography because maybe they're not eligible for colonoscopy or that kind of. And we're actually doing some more research on that point because it's a little bit out of the side of the program. They do have the results go back to Screen IT again, the IT system. So there is an option, but it's not really common. Okay. Did I miss another question, Tamsin?
No, I think that's good. Let me bring in a few of the other panelists because we've had some more questions. We've got a question directed at Professor Regula, who says that if the quality of the colonoscopy is high, it can even be done after 17 years. That's somebody has said that this is a result of a recent study, and you've been asked to comment on this, Dr. Regula.
Yes, this is the study from our center. The first author, Nastasia Pilonis, published in Annals of Internal Medicine, and indeed, if the colonoscopy is high quality, defined as the very good bowel preparation, endoscopies of a high adenoma detection rate, with total colonoscopy, so reaching the cecum, then the effect of such a negative colonoscopy, as also was presented during the first presentation, in our study reaches 17 years. So it's really very valuable examination if high quality, if no finding are there in the normal colonoscopy, then indeed it is valid for up to 17 years. So it's very good news.
Thank you. We've got, and we now got a couple of questions that I think are worth exploring with the panelists, which the first one, let's pick up this issue of culture and attitudes and fear, that people are reluctant to take a test, or they fear a colonoscopy. You know, do they fear the test more than cancer? That's a question that we've asked. What can we understand about this, and do we need some more robust behavioral studies to understand, you know, what people's perceptions and motivations are? Who wants to pick that up from the panel? Morten, yes, go ahead.
I think the majority of the participation do not take the test to be to find a cancer. They want to be ensured that they are healthy, and that's quite a different way to do it. Because I mean, if you want to be sure that you are healthy, you should go for colonoscopy screening, not a FIT screening test with a sensitivity on 75 to 85%, depending on the cutoff level. But I mean, that's the normal human reaction. I mean, it's the same when I take a COVID test. I mean, I don't take a COVID test to be sure that I have the COVID disease, but I take it to be sure that I don't have it, so I can participate or doing my work every day. So it's a little bit the same thing with the majority of the screening participation. They actually do perform the test to reassure that they are healthy.
Okay, thank you. We've got a couple of more comments coming in on this issue. We've got a message from Iga, who says that 14% of patients with metastatic colorectal cancer in Poland, when asked if they would do a colonoscopy, they refused, and that's absolutely shocking. I mean, if you got to the point where you got a diagnosis and then they were asked for this test, they refused. Maybe we can pick up on that, but I think it shows that we have some cultural barriers, we have some fears, and we have some challenges. And you know, if you need to get your population to willingly engage in a process, we need to have some understanding about what the issues are, whether they are issues of stigma or intimacy or shame or embarrassment, or just a lack of wanting to acknowledge that there might be a problem. So I think this is something that we really need to pick up on. There's another element that's come up in the chat that I think we could perhaps explore, which is that when there's a choice between a colonoscopy and a FEAT test, that some people might view the FEAT test as somehow being a second quality. That if you're not getting expensive equipment, it's not really done in a hospital environment, it's not a real test, and that they're being fobbed off with a cheaper version. Is this an issue with anyone? And maybe this is a question I think that was addressed to Professor Regula. And maybe Sylvain, you can also share, is this something that you have in France? Do people want a real solid test done in a hospital by a man in a white coat? Or is there quite high levels of support and belief in the credibility of the FEAT test?
We, providing the choice, sent also the information about both tests, and it was well balanced. So there was no inferiority of any test mentioned there, of course. So I don't think this is the problem, that the people do not trust FIT testing. I think if the education is okay, then the balance is okay, and it should not be the problem, I think.
Sylvain, do you want to come in on this issue?
Yes, I think education of the population and the medical community is a very key point, very important key point. I don't think the population know something about the test of the validity of the test. I think they don't care. They just want to be informed. And I think education of primary, secondary prevention are very, very, very important in every population at every age.
Thank you. I now want to pick up on a couple more points that have come up in the chat, and maybe one that I think is worth exploring is the issue of trust. Because we've had a message in from Natasha, who said that media campaigns in her country are not very well accepted because they're often fronted by politicians, and therefore the population think it's some political campaign of a political party that wants to get votes. And we really need to think about who should be the face of these campaigns, because the credibility of the messenger is so important. And with the COVID outbreak, we've seen very high levels of mistrust of both science and government action in this area. So how do we get the trust of the population in a system, in a campaign? And if you're trying to put out messages, how do we make sure the messenger is credible to the audience? Who would like to come in from the panel? Anyone who wants to pick up on that? Sylvain, I mean, France is a country with notoriously high levels of disbelief in areas of, for example, vaccines and others. In France, how do you build trust here?
It's very difficult to answer that. I don't know why the population is reticent to screening or vaccination. I think as someone say in the chat, they are against politician or not. It is not very clear for the population if it is a politician decision or a health ministry decision. Population health, it's not very clear for the population. They think that it's a politician decision, so they are perhaps afraid or reticent. I don't know. I think psychologists are very important, and sociologists to answer to this question.
Okay, thank you. We've had a couple of messages coming in about the issue of sedation, and that maybe one of the areas to increase participation is people are frightened of discomfort and pain, and therefore offering deep sedation might be a way to deal with that anxiety and increase participation, and that this might be an area for advocacy for patients. Is there anyone from the panel who wants to pick up on that? Morten, I can see you want to say.
Yeah, well, this is a tricky thing because I mean, about 1/3 of the person who's coming for the colonoscopy, they actually don't want any sedation at all because they want to be sure that they can take their car home. But of course, there's some fragile persons, and the only way we can pick them up in Denmark is that we can see them when they participate in where they show up in the colonoscopy room, and you are not have any doubt that they are very afraid of it. And sometimes we can normally we can if they are suitable for it, we can give them a propofol sedation so they sleep, or we can reschedule them. And I think with this alternative, we actually have a very high success rate, but you need a nurse more to give the propofol sedation. So actually, in my screening department, we have a very good succeed with that approach, but you need to have more resources to do that on location.
Thank you. Yes, Professor Regular, you wanted to come in.
A word from me. It's not available. That propofol sedation is restricted to the anesthesiology personnel in most countries, not all, but in most countries in Europe and the world. So this is the problem. And the other types of sedation is suboptimal, as you know. So there is one more complication to that. And if we want anesthesiologists, they are currently busy with COVID, of course, and there is not enough of them, and this increases the problems that we have.
Thank you. And indeed, somebody in the chat has also said that one of the problems is that you must have a negative PCR COVID test now, even before colonoscopy. So that's now adding a level of complication. I'm going to bring this panel to an end because we've got, when we move on to the next one, we'll be picking up on this. But I want to say thank you to everyone who's put information in the chat. It was extremely helpful for our panelists to understand where there is room for sharing and questions and to take it forward. So thank you. And one of the messages was that is there any point in trying to increase screening participation if you then can't get the test? You can send out the invitations and there's no capacity. So this is something, again, to bear in mind, that you may have some governments who are reluctant to try and increase the participation in screening because they know they don't have the resources in place to then offer treatment. So they would raise expectations and without being able to deliver on it. So can I say a fantastic thank you to our first panel. That's to Iris, Sylvain, Mortin, and to Professor Regular. Thank you very much. And we will now move to our second panel.